A very good evening, everyone. Today we will be taking up the current topic of artificial intelligence in ophthalmology. I'm Dr. Ankita Sharma. I'm a practicing ophthalmologist, and today I will take you on a tour of this topic and the various aspects of it and the clinical applications in the field of ophthalmology. So our learning objectives today will be to understand what is the concept of artificial intelligence in totality, the various techniques of AI, the algorithms of machine and deep learning, the history of artificial intelligence in ophthalmology, how it has its current applications in specific ophthalmic diseases, the promises that it holds, the perils which it is fraught with, and the future prospects of AI in ophthalmology. So we have these four stages of industrial revolution, and currently we are in the fourth stage of cyber physical systems. So what is AI actually? So this term was actually coined on August 31st, 1955 by the Revered John McCarthy et al. In their A Proposal for Dartmouth Summer Research Project on Artificial Intelligence. So artificial intelligence means that when there is simulation of human intelligence by a software or machine. So it's the ability of a computerized system to show cognitive abilities like memory, language. So the first scientific step towards the development of intelligent machines was by Alan Turing, who in 1950 had conducted the famous Turing test. So here there was an interview with open-ended questions to determine whether the intelligence of the interviewee is human or artificial, and if this distinction could no longer be made within certain predefined margins, that means true machine intelligence had been accomplished. So here the machine had become equivalent to a human. So there are various techniques, and like we have a superset and then a number of subsets under it. So the bigger superset that we have is artificial intelligence. So it is as I told earlier, the engineering of making intelligent machines and programs. Under it comes machine learning, where the machines have the ability to learn without being explicitly programmed. That is, there is no supervised learning. They are basically given an algorithm, they process it, and they learn from those algorithms how to do the procedure. Deep learning is another subset of machine learning where we even delve deeper, and the learning is based on deep neural networks. So here also we can see in the Venn diagram that artificial intelligence with a subset of machine learning, then deep learning, and within deep learning we have various convolutional neural networks. So a convolutional neural network is basically a deep learning algorithm consisting of layers that receive the inputs, they assign importance or weightages to the inputs, they cluster the similar inputs, and they keep the dissimilar inputs separately. Then it is used for image recognition, processing, and finally classification. So these are the various convolutional neural networks or the artificial neural networks. So why did we give the term of neural networks firstly? So this is because just like in our brain, in our nerve terminals, we have these dendrites, then we have the nucleus, the cell body, and then the axons, and then finally terminating in the synapses. So similarly, like we receive the inputs in the AI algorithms, then weightages are assigned, and then finally it is processed and classified. So they work on an analogy with the human brain, with the nerve terminals, hence they are called as artificial neural networks. The convolutional neural network, it is based on that only, and it has a number of layers. So we get the input, then there is a convoluted layer, and then after that there is a maximum pooling layer, and we finally come out with the output. So there's something called as integrated gradient method. Like in this, we have these kind of topographical maps. So it is a type of open artificial intelligence. That is, in the maps, we have certain highlighted areas, and those coincide with the clinical picture as seen here in the retina. Means where this highlighted portion is there, we can see that the corresponding clinical lesion is present in the colored fundus photograph. So algorithms in machine and deep learning. So there are some conventional machine learning algorithms and deep learning algorithms. So in machine learning, we have supervised learning. For example, the linear regression, logistic regression. Then there is the decision trees, neural network methods, unsupervised learning. We have k-means, expectation maximization, reinforcement learning. We've got Q learning, temporal difference learning. Then in deep learning, we have the deep belief networks and like the convolutional deep belief network, then convolutional neural networks like AlexNet, GoogleNet, visual geometry group network, deep residual learning, and so on and so forth. And we have some recurrent neural networks which works on a feedback mechanism. So it is bidirectional because we are giving some inputs, then after processing of the algorithm, the feedback that we are receiving, on the basis of that we are modifying the algorithms. And this also has another example of long short-term memory. So the common algorithms in artificial intelligence, as we had seen, there's something called as SVM, support vector method. These are the various convolutional neural networks, as we can see in C. And these are the recurrent neural networks where there is an agent, then some action is conducted on the environment, and then the environment exerts its own feedback on the agent, and hence the entire algorithm gets modified. So how machine learning works? So as we said, there's an unsupervised and there's a supervised learning. So in supervised, like they will be provided with a set of instructions which they have to follow. Whereas in unsupervised learning, it will be without any preset instructions. And so the example which comes under unsupervised is clustering of similar kind of things. Whereas in supervised, we have got classification and regression. Regression basically means where we can predict some outcome. So there have been a number of studies on the use of AI in ophthalmology, and the maximum studies, as we can see in this bar diagram, is in the field of diabetic retinopathy. So the general applications in ophthalmology, it can serve as a diagnosis assistant, as a tool in medical imaging, for disease risk prediction, for drug discovery, as a research platform, and in proper hospital management. So here we can see that the convolutional network is being processed, in which there's a input layer followed by a number of hidden layers and finally an output layer. For example, we have a number of clinical and imaging inputs. We have visual acuity, the IOP, the optic nerve imaging, the various diagnostic procedures that have been conducted, history, the fundus examination, genetic inputs, OCT, RNFL, imaging inputs, and finally leading to an output. So this is how AI works, amalgamates all the inputs and comes out with an output. So the applications of AI in specific diseases: in anterior segment, we have keratoconus and other anterior segment disorders. Then it can also be put to use in refractive surgeries, cataract surgery, and IOL power calculations. In the posterior segment, it finds use in diabetic retinopathy screening. As we can see, a number of inputs, they are being combined to produce a clinical photograph. Then age-related macular degeneration. Then glaucoma screening and diagnosis. In retinopathy of prematurity screening. So these are the different uses in the anterior segment. Like on slit lamp, it can help us in cataract detection and grading, conjunctival hyperemia grading, high intraocular pressure detection, identification and localization of conjunctiva, cornea, and lens diseases. On retroillumination, it can show us how a posterior capsule opacification is progressing. On ASOCT images, it can help in angle closure detection. On tear film lipid layer interference images, it can help us to classify dry eye. On frontal eye videos after fluorescent installation, it can again classify dry eye and provide us with a tear film breakup time calculation. So the need for AI in keratoconus screening, it helps in an accurate identification of keratoconus at an earlier stage, so that we can accordingly plan the refractive surgery. Corneas which have undetected keratoconus, they are known to be highly associated with iatrogenic keratosia, which is the most severe and irreversible complication after laser in situ keratomiliosis or LASIK. With the availability of therapies such as C3R, that is corneal cross-linking, early detection can also contribute to delaying or stopping the progression of keratoconus. However, the keratoconus identification, it can be challenging clinically in its earlier stages because visual acuity at this stage remains good and there is no specific clinical corneal finding. So here is where AI comes and to our aid, because like here we are imaging a normal cornea. So there's an ultra high resolution imaging on OCT and we are using sheen plug images. So there has have been studies on use of deep learning in keratoconus screening. So these were the various list of parameters which were measured by Pentacam high resolution system, ultra high resolution OCT, and submitted to the neural network classifier for discriminating subclinical keratoconus and keratoconic corneas from normal healthy corneas. And they have really come out with very good outputs and have uh, been able to differentiate between subclinical and clinical keratoconus to a great extent. So discriminating between normal and keratoconic corneas. So here is how machine learning helps improve the diagnostic ability of subclinical keratoconus using sheen plug and OCT imaging modalities. There are further studies on the deep learning in diagnosis of keratoconus. So there was a diagnostic accuracy study which was a single center study. So there were a total of 304 keratoconic eyes according to the Amsler-Krummeck classification and 239 age-matched healthy eyes. So the main outcome measures here were the diagnostic accuracy of keratoconus using deep learning of 6 color-coded maps, that is the anterior elevation, anterior curvature, posterior elevation, posterior curvature, total refractive power and pachymetry map. So the results that we found were that deep learning of arithmetical mean output data of these 6 maps actually showed an accuracy of 0.991 in discriminating between normal and keratoconic corneas, which is really magnificent, and it shows that how much artificial intelligence can help us in the diagnosis. So these were the various 6 color-coded maps as we had seen: the anterior elevation, the posterior elevation, the refractive power, the axial power of the sagittal power, keratometric and posterior, and finally the thickness, that is the pachymetry maps. So the critical analysis of the study here was that deep learning using the image of corneal color coded maps with anterior segment OCT based on clinical diagnosis has not so far been investigated for keratoconus detection and grade classification. It will be an aid not only for the screening but also for the grade classification of the disease, but the limitations were that it was not applied to other corneal disorders such as form fruste keratoconus. Form fruste is the topographical keratoconus, that is, which you only catch on the keratometric maps, topographical maps. Subclinical keratoconus or post-surgical eyes. The arithmetical mean outputs from the 6 classifiers without any weighting were utilized for classifying the grade of the disease. So, further we come to another segment where we can put AI into use, that is in refractive surgery. So as we know, over the years it has undergone rapid advancements with good visual effects and long-term safety with the new advances. But and many of the surgeries are available. Some are cornea-based surgeries, some are lens-based surgeries. So these are the surgeries which are with the aid of laser and are in vogue currently, like photorefractive keratectomy, LASIK, and small incision lenticule extraction. So more and more amount of clinical data currently is being generated related to these kind of surgeries, and we need more accuracy for the pre-operative assessment and screening. So therefore, artificial intelligence here assists in diagnosis as well as helps in the surgery procedures, like deep learning, how we do the pre-op assessment in refractive surgery. So we take inputs of both the demographical data as well as the clinical data, like the sex, age, medical history, the medications, whether the patient is having any use of glasses or lenses, the optometry, the refractive error assessment, and then we conduct a number of imaging like OCT, optical aberration screening, corneal topography, tomography, confocal microscopy, corneal biomechanics study, and family history. So on the basis of this, we run a number of algorithms on AI, and the output which comes in the form of diagnosis, classification, and management is assessed. So on the basis of that, we are able to take a call on what kind of surgery is most patient suited and should be done. So why it helps us here is because when we have, firstly, to manage such a huge clinical decision database, and secondly, to reduce the amount of errors, to reduce the misdiagnosis, to save time analyzing patient data, to integrate multimodal data, and also to enhance patient trust in the management. So, very important in refractive surgery is the use of deep learning in clinical ectasia assessment. So we have to see like which patients are more susceptible to corneal ectasia. So a multi-center case control study was conducted by Lopez et al. Here artificial intelligence models were generated using Pentacam HR parameters to discriminate the preoperative data of three groups. One was stable laser-assisted in situ keratomiliosis cases, ectasia susceptibility patients, and clinical keratoconus patients. So we had run the random forest model. It provided highest accuracy among the AI models in this sample with 100% sensitivity for clinical ectasia. That is, it was able to find out uh, the without any error 100% of the cases who actually had clinical ectasia from those who did not. So PRFI had an area under the curve of 0.992 being statistically higher than the Bellin-Ambrosio deviation. So this also shows us that how it has been able to detect clinical ectasia and help us in refractive surgery. So these are the prediction of candidates who are suitable for corneal refractive surgery. So this is the classification performance of various machine learning models to predict the candidates who are suitable. So there has been a tenfold cross validation in the training set. So that's how the machine learning techniques with feature selection, like they select some particular features, and then on the basis of that they analyze, they were significantly superior to the classic models. So that's why feature selection methods are better, like supposing a patient has thin cornea or has some other topographical index. So all those features, it combines them, it runs an algorithm and is able to come out with the suitability of the candidate for the surgery or not. So not only does it help us in the pre-op screening and the diagnosis, it also helps us in keratoconus management. Artificial neural networks have been used to guide intracorneal ring segment implantation, and this has been able to provide us an increase in the visual acuity and the spherical equivalent. Uh, Also, refractive surgery is not alone. Basically, nowadays we are advancing the cataract surgery towards refractive surgery. So, according to WHO, it is estimated that approximately 32 million cataract surgeries will be performed on a yearly basis as of the year 2020, making it the most commonly performed surgery in the field of ophthalmology. So, an appropriate consideration of IOL selection and placement allows it to become the ultimate refractive surgery. So this is the prediction phase, like we already on the basis of post-op refractive errors, we are able to, and the assessment of the parameters like axial length, anterior chamber depth, lens thickness, age, gender, we are able to understand like this IOL we had implanted, these were the parameters, clinical parameters of the patient. So we have run a machine learning regression algorithm. So we came up with a post-op spherical equivalent obtained with the implanted IOL power. So this can give us a predicted spherical equivalent for a given IOL power. So from the next time that we want to implant an IOL, from the beginning only we will be able to know that how much post-op spherical equivalent it's going to induce, and accordingly we can plan the IOL power. There are a number of AI-based formulae that are currently in use in cataract surgeries. So we have the Hill radial basis function formula, which is entirely data-driven. It's a neural network using non-linear radial basis activation function in the neurons composing its hidden layer. Then also we have a very good modality where we can achieve existing intraocular formulae in 3 dimensions. So we came there was something known as Ladas super formula. So in this Ladas super formula, there was a plus component to evolve the existing formula. That is, for example, we can see here, these are the third generation intraocular lens formula in 3 dimensions. So we are having so many formula. So all of these formula, we can choose the best aspects of each and we can combine them and we can come up with a 3D formula which becomes a super formula which is going to be best patient suited. So this is going to maximize the accuracy in the IOL power implantation. And similarly, we have another formula based on AI, that is the Pearl DGS formula based on the um, thick lens formula. The AI in diabetic retinopathy, so now we have entered the posterior segment. So it finds its uses there as well. Diabetic retinopathy is the main specific complication which affects 1/3 of the diabetic population and is a sight-threatening condition. So in April 2018, the US Food and Drug Administration had approved an AI algorithm which was developed by the company IDX. It is used along with a Topcon fundus camera for diabetic retinopathy identification. So a study had been done on 900 subjects in a primary care setting with automated image analysis. So 245-degree digital images per eye, one centered on the macula and one centered on the optic nerve, were obtained and analyzed. And these images were compared with the stereo wide field fundus imaging interpreted by the Wisconsin Fundus Photograph Reading Center. So let's see how it helps us to classify patients who are having diabetic retinopathy or not. So by autonomous comparison software, it provided us with one of the two results. That is, if more than mild DR was detected, we had to refer the patient to an eye care professional. And if the results were negative for more than mild DR, that is MTM-DR, then we had to rescreen the patient in 12 months. So based on this analysis, we were able to come up with a new entity called more than minimal DR. So how was it defined? The presence of early diabetic treatment retinopathy study level 35 or higher. That is, clinically we have microaneurysms plus hard exudates, cotton wool spots, and or mild retinal hemorrhages and or DME in at least one eye. The sensitivity and the specificity of the technology was 87.4% and 89.5% respectively for detecting more than mild DR, which is a good amount. And also we can have anti-VEGF outcome prediction and dose optimization in DME. So that is how this IDX-DR has been able to help us in the detection of diabetic retinopathy. So this is how an analysis report in IDX-DR comes. So it's going to tell whether it is negative or positive for diabetic macular edema. So there have been a number of AI algorithms for DR screening from various countries. Like IDX-DR, as I've already mentioned, this was the first AI autonomous diagnostic device to be FDA approved, and it's of USA. Similarly, we have iArt, which has been FDA approved, and RetMarker DR from Portugal. We have our own indigenous Medios AI from India. So it is actually integrated into an offline smartphone app which is to be paired with the Remedio fundus on phone device. So that is how we will be able to find whether the patient has DME or not. So this is a red marker processed image, how it comes up whether we have diabetic retinopathy or not. This is what we see in eye art. So when it is red, it is going to clearly tell us that we can see the clinical photograph, and it is going to tell us that clinically significant diabetic macular edema is possibly present or not. So we see a probability over here, possibly proliferative DR. Uh, that is because there might be some neovascularization, but basically it helps us to point out whether DME is present or not. So here was a difference between what was the sensitivity and specificity of IART and ret marker. So IART was 94.7% sensitive for any retinopathy and 93.8% for referable retinopathy and 99.6% for proliferative retinopathy. Whereas red markers was 73% for any retinopathy, 85% for referable retinopathy, and 97.9% for proliferative retinopathy. That is where we have any evidence of neovascularization. Similarly, we have something called as a fluid intelligence app. So it helps us to know whether there is presence of any macular edema. So it is going to classify the macula as actively wet. Like the AI algorithm is 99% confident of the macula being wet. But the thing is that the exact diagnosis here will not be given. It will all depend on your clinical findings. So it will just give you like a cafeteria approach that there are a number of causes for macular edema like DME or wet ARMD, cystoid macular edema, following cataract surgery, that is Irwin gas syndrome, or the edema is because of BRVO, CRVO, or CSCR, or any other cause for that matter. So here, as I discussed, the indigenous software of Meteos AI for DR on smartphone, the study looking into 900 adult subjects with diabetes in India, where 5 retinal specialists they graded images taken with Remedio mobile camera for any DR or referable DR. This was later compared to the Meteos AI software running offline on an iPhone 6. So Meteos AI had achieved good results with sensitivity and specificity pair for any DR of 83.3% and 95.5%, and for referable DR as 93% and 92.5%, which is really good. So if we are able to refer 93% of the patients who are truly having diabetic retinopathy, we'll be able to provide them with early treatment and early respite from their symptoms. So this is how that Remedio's fundus on phone device looks like, and how it is capturing the images and help us know whether we have diabetic retinopathy or not. So this is on the iPhone. So it clearly tells us that no diabetic retinopathy detected. And similarly, if diabetic retinopathy is detected, it will tell us. So the need for deep learning in glaucoma diagnosis. So now we come to glaucoma. So it is a leading cause of irreversible blindness with a global prevalence of 3.5% and a global burden of 76 million affected people in 2020. The early detection and treatment can preserve vision in the affected individuals. However, glaucoma is asymptomatic in the early stages, as visual fields are not yet affected until 20 to 50% of the corresponding retinal ganglion cells are lost. So this is actually the stage of pre-perimetric glaucoma, where the visual field is still not showing any signs, but we can still catch the disease. So here is where AI has its very pertinent role. So the various applications of AI in glaucoma that we can have is, firstly, they can help in diagnosis. So whatever data we have, that is the fundus photography, OCT, visual fields, demographic features, and the intraocular pressure, it can segment it, it can have an object detection, and then classify the patient as glaucomatous or non-glaucomatous. Then also by longitudinal analysis, it can cause a visual field forecasting, structural loss forecasting. Then it can help us to come up with a structural functional relationship discovery, knowledge discovery, that is the age, gender, or race prediction from the OCT images, that is these people will be having glaucoma or are going to later develop glaucoma or not. Then image enhancement, speckle noise, it helps us to reduce the noise on OCT images and to in turn cause signal accentuation. So this is how we have taken the images, and it is going to segment and come up with a 3D convolution, go through a 3D convolutional neural network and come up with this 3D image helping us to classify glaucomatous from non-glaucomatous patients. The deep learning and the detection of the glaucomatous disc. So this is very important. The first thing that we always see clinically is cupping, loss of the neuroretinal rim, the RNFL defects. So assessment of the optic nerve head integrity is the foundation for detecting any glaucomatous damage. So for that matter, we take the clinical photographs as input. So as I had told that feature identification, the feature learning, so it goes through a number of hidden layers, and then there is a lot of back propagation. Means it goes and then again there is a feedback, and then finally it tells like these many patients have probability of being glaucomatous, like 90% glaucomatous, and 10% of the patients have probability of being non-glaucomatous. And finally it's able to come with an output that yes, this patient has glaucoma, and no, this patient does not have glaucoma. So we call it a black box AI. Now, why I say so, that is because there's a difference between the black box AI and the open AI. The open AI, that is previously in the initial slides I had mentioned about the integrated learning. So black box AI is when we do not know, we are not aware of the processes that the patient's clinical photographs or data is undergoing to come up with a classification. Open AI is when we know that what all parameters are being assessed. That is, we know that the disk is being localized and segmented, or we have a number of heat maps or attention maps of AI, and we are processing them, and then we are finally coming up with a diagnosis. So yes, it is always better to have an open AI system which helps us to know that actually which all parameters were analyzed and helped us to come up with the diagnosis. So similarly, we have this Netra AI. So this retinal fundus photo of left eye of a glaucomatous patient is there. So in which we can see that there is a vertical cup disc ratio. It is increasing, and we can classify the patient as being a glaucoma suspect. So AI in OCT analysis for glaucoma diagnosis. So an accuracy of 93% based on expert opinion was reported for a hybrid deep learning ANN analyzing single scan swept source OCT data to classify eyes as normal or glaucomatous. An MLC using PCA to analyze SSOCT RNFL thickness maps was shown to outperform visual field global indices and spectral domain OCT RNFL's regional thickness measurements with an area under the ROC curve of 0.95 for detecting stereophotograph defined glaucoma. It also detected higher progression rates in comparison to the same matrix. An anterior segment OCT image analyzed by Nave Bayes classifier identified predominant mechanisms of angle closure with 85 to 89% accuracy. That is, those patients who had an exaggerated lens fault, pupillary block, thick peripheral iris roll, and plateau iris, they were more predisposed to developing an angle closure glaucoma. AI is not only useful in the disk classification and the classification of OCT images, but also it provides automated gonioscopy. So, an independent test set of 39,936 swept source OCT scans from 312 phakic patients was analyzed. Participants above 50 years with no previous history of intraocular surgery were consecutively recruited from glaucoma clinics. Indentation gonioscopy and dark room swept source OCT were performed. For each subject, all images were analyzed by a deep learning based network based on the VGG16 architecture for gonioscopic angle closure detection. So the results that were there were the area under the curve of the deep learning algorithm was 0.85% with sensitivity of 83% and specificity of 87% to classify gonioscopic angle closure with the optimal cutoff value of greater than 35% of circumferential angle closure. So these were the images of the patient taken, and when they were run through the convolutional layers, we were able to find that in 30% of the cases the angles were open, whereas in 70% the angles were closed. The applications of AI also come in handy in visual field interpretation. So the first use of MLC to discriminate normal and glaucomatous visual fields occurred in 1994. So in this case, an absolute threshold sensitivity at each field point was analyzed by an ANN with back propagation, and it yielded results similar to experts' opinion. So this network categorized normal eyes and glaucomatous eyes with sensitivity 65% and specificity 72% comparable to two glaucoma specialists. Lee et al. Suggested that there are patterns, possibly within adjacent and distant test points, that deep learning algorithms are able to detect that clinicians actually don't appreciate. So, like applications, an unsupervised algorithm employing a corner learning strategy called archetypal analysis was developed to classify quantitatively the regional patterns of loss without the potential bias of clinical experience. Like some people, they had some regional uh, patterns of visual loss, which this corner strategy or archetypal, like there were some who were predisposed to developing open angle glaucoma, so or normotension glaucoma. So those archetypes were able to help us find that. So Humphrey's visual field, they were subjected to unsupervised learning to identify such archetypes or prototypical patterns of visual loss. So they actually provide us with a regional stratification of a visual field, along with coefficients that weigh each of these regional patterns of loss. Patients with high weighting coefficients for a particular archetype, for example, consistent with an advanced glaucoma, were more likely to have higher cup disc ratios than patients with high weighting coefficients for other archetypes. Archetypal analysis was useful in predicting reversal of a glaucoma hemifield test back to normal after two consecutive outside normal limit results, largely because it accounted for lens rim artifacts and even brought into account the non-glaucomatous loss patterns. So this is how the archetypal analysis is there. Like these type of archetypes are providing us with an inferior nasal defect, inferior altitudinal defect, inferior paracentral defect, and they will help us to classify the patients accordingly. These are also the various archetypes that help us to know what stage of glaucoma the patient is in. Combining the structure and function in glaucoma diagnosis is very important. The global visual field indices, like the mean defect, the corrected loss variance, and short-term fluctuation, in combination with the structural data like cup disc ratio, rim area, cup volume, and nerve fiber layer height, analyzed by an artificial neural networks, it was capable to correctly identify glaucomata size with an accuracy of 88% in an earlier study. So this figure was higher than that of the same artificial neural network which was trained with either only structural or only functional. So when we take into account both structural and functional parameters, then we are able to come with a stronger glaucoma diagnosis than having either of them alone. So need for an AI in now coming to age-related macular degeneration. So ARMD it accounts for approximately 9% of the global blindness and is the leading cause of visual loss in developed countries. The number of people with AMD worldwide is projected to be 196 million in 2020, rising substantially to 288 million in 2040. So there are two forms of late AMD, the neovascular or the wet AMD, and the atrophic, that is the dry AMD, which in its advanced stages is defined by geographic atrophy. So this is the dry AMD with pigmentary changes in a large drusen, and this is the neovascular AMD where we can see CNVM. So there have been a number of studies for the use of deep learning in ARMD. Like there was a study by Berlina et al. In 2017. So they classified referable and non-referable AMD based on colored fundus photographs. Then classification of 4-class AMD severity was based using color fundus photographs. Dry AMD detection being done using OCT images by Carey et al. And Lee et al. Then 9-step ERIDS, that is age-related eye disease study severity scale using color fundus photographs and an ensemble model. Wet AMD detection using ultra-wide field. So there were a number of such studies, like on a severity scale of either 4 points or 9 points, it was able to classify the severity of ARMD. So over the years, we are seeing, especially in the recent ones, that a number of studies have come up. So this is very important. There is the results of the studies of deep learning in AMD. Like the study by Berlina et al. Of a 4-class AMD severity classification, 79.4% versus 75.8% in accuracy for machine and physician grading respectively. So we see that machine grading was superior. By Grassmet et al. In that the results were overall accuracy of 63.3%, again outperforming the human graders. By Chen et al., evaluation on both the ERIDS as well as the ERIDS2 data sets showed that the accuracy of the model, that is the AI model, exceeded the current state-of-the-art model. Means whatever the current modality of detection is being used. So that was exceeded by a ratio of 10, means it was greater than 10. So again, the machine learning was more accurate. So how can we detect AMD on OCT using deep learning, and how can we prognosticate? Lee et al. Developed an algorithm to categorize OCT images as either normal or age-related macular degeneration. So these images were linked to clinical data points from the electronic health record, and gold standard labels were extracted using the International Classification of Disease 9 diagnosis codes At a patient level, the model achieved an area under the ROC curve of 97.45% with an accuracy of 93.45%, which is really good. So in recent analysis of AREDS2 data, the risk of progression to geographical atrophy was significantly higher with reticular pseudodrusen presence. A study developed a system for predicting progression to wet AMD in the second eye using OCT images. So this study was done by Yim et al. Um, where they were predicting conversion to wet AMD using deep learning. And they had a sensitivity of 80% and specificity of 55%, again outperforming 5 out of 6 experts. So these are the performance of the various studies using AI for the detection of AMD, and we can see that really the sensitivity here is 88%. Here the pool specificity is 90%. That is, it is able to easily pick up the true positives and the true negatives. The need for AI in ROP screening in the newborns. So as we know, ROP it accounts for 6 to 18% of childhood blindness worldwide, and the decision to treat is primarily based on the presence of plus disease. So if anybody is not knowing what is plus disease, so we have to have the three characteristics. That is, there will be vitreous haze, there will be poorly dilating pupils, and along with that there is going to be engorged and tortuous vessels. The engorged, that which I mean dilated and tortuous retinal vessels. So but the problem is that the clinical diagnosis of plus disease, or for that matter any stage of ROP, is highly subjective and it is variable between the experts. So that's why we need a machine to accurately diagnose it. So there have been a number of there has been a spectrum of ROP screening models that have been used by using AI. So firstly is to do this ophthalmoscopic screening, then digital wide field imaging, we can use Optos 200x, then feature extraction based models, manual or semi-automated. So there was something called as ROP tool, then retinal image multi-scan analysis, vessel map, computer assisted image analysis of retina, and now we have come to the AI based methods where we can use support vector machine learning, deep learning, convolutional neural networks for the ROP screening. So deep learning, how can it help us in automatic detection of the plus disease, which is really sought after? So a deep convolutional network was trained using a data set of 5,511 retinal photographs. Each image was previously assigned a reference standard diagnosis based on consensus of image grading by 3 experts and clinical diagnosis by 1 expert. That is, whether the patient is normal or pre-plus or plus disease. So images were collected from 8 academic institutions participating in the imaging and informatics in ROP cohort study, that is IROP. The deep learning algorithm was tested against 8 ROP experts, each of whom had more than 10 years of clinical experience. Results for diagnosis of plus disease in an independent test set of 100 retinal images, the algorithm had actually achieved a sensitivity of 93% with 94% specificity. And for detection of pre-plus disease or worse, the sensitivity and the specificity were 100%. So this is how AI is really revolutionizing the ROP screening domain. So this is how plus disease looks like. I think everybody is able to identify the tortuosity and the dilatation of the vessels. So also we need to monitor the disease progression of ROP. So here also deep learning can help us. So can a quantitative measurement of ROP severity be tracked over time? So in this cohort study of 871 infants with 5,255 clinical examinations, a quantitative retinopathy of prematurity vascular severity score developed using an automated deep learning based plus disease algorithm identified differences in the mean severity of eyes progressing to treatment requiring ROP compared with eyes that did not require treatment using only a posterior pole clinical photograph. Meaning that is, tracking quantitative measurements of ROP severity may be an effective method of identifying the patients at risk for disease progression, and hence those ones only which need future ROP treatment. So this photograph shows us that how we can monitor the progression with a quantitative DL based severity scale. So there is a vascular spectrum. ROP diagnosis and AI. So here I've just enlisted a few models that have been used, like for diagnosis of plus disease, as I had already discussed in detail, the IROP-DL model, disease severity DPROP, which has been brought out by Wang et al. To demarcate zone 1, a model was brought by Zhao et al. And stage detection, Moulet et al., they were the first to report the identification of a peripheral ROP ridge directly in a fundus image. So thus we can see that deep learning seems to hold promise for automated and objective diagnosis of ROP in digital fundus images. So it will both save us the time and labor and also provide us with accuracy. So what are the various advantages of AI in Opthal? So we have seen so many uses in the past slides. So it can outperform doctors at times, and it helps us to diagnose what is presently undiagnosable. It helps us to treat what is presently untreatable and what is presently unrecognizable. It can predict the unpredictable, classify the unclassifiable, decrease our workflow inefficiencies and save time and money and work, decrease hospital admissions and readmissions, increase medication adherence, decrease the patient harm, decrease or eliminate misdiagnosis, which is very, very important, and provide us with a personalized high precision medicine. That is, it is helping us in the pursuit of pharmacogenomics. So the practical challenges in the application of AI in clinical settings. So the first leads to bring about workflow integration. So it is very important to understand the technical, the cognitive, the social, and the political factors in play and incentives impacting integration of AI into the healthcare workflows. Then to enhance the explainability and the interpretability among all members of the healthcare team. Then educating the workforce properly about AI and machine learning approaches. Then the most important, that is the oversight and the regulation to maintain data privacy, because there is so much of data in the clinical domain and in the computer systems, so this can be misused, so we need to maintain data privacy. Then the problem identification and the prioritization, because there is something called as moral decision making. That is, at times humans are able to decide with using their emotional intelligence that this patient is more important at this point, but maybe a machine is not able to make that moral decision making. So that is one problem. Then the clinician and the patient engagement, that is to have a proper patient provider interface. It should not be that the reins completely go into the hands of the machines and the humans are left helpless and they are not able to exercise control. So we need to exercise control, but minimally, and at the same time ensure accuracy and data quality and access. That is, good quality data, both structured and unstructured, needs to be maintained. And we need to integrate the non-clinical data also to develop effective AI tools. So as mentioned earlier, these were the challenges that we are encountering currently in the integration of AI into the clinical settings for both diagnosis and management. And in the words of the WHO, which had identified 6 key areas of ethical concern, they do deserve mention. Protecting human autonomy, promoting human well-being and safety and the public interest, ensuring transparency, explainability, and intelligibility, fostering responsibility and accountability, ensuring inclusiveness and equity, and promoting AI that is both responsive as well as sustainable over generations. So, does AI hold some promises for the future? What does it herald for us for the future? So there are a number of applications on which a number of studies are ongoing, like retinal microvasculature analysis potentially predict the cardiovascular disease risk factors, example blood pressure, diabetes, direct CVD events, retinal features, and CVD biomarkers, example coronary artery calcium score, by the Google DeepMind Health. Then it can help in automated grading of cataracts, managing pediatric conditions such as refractive errors, congenital cataracts, detecting strabismus, predicting future high myopia, and diagnosing reading disability, to automatically detect leukocoria in children from a recreational smartphone or digital camera photographs, measuring inner and outer retinal layer thicknesses to predict the risk for Alzheimer's disease, in oculoplasty for measuring referable blepharotosis, and also in ocular oncology for grading of the tumors, high fidelity mobile holograms, and extended reality for remote healthcare through upcoming 6G. This could help us to shape the coming phase of telemedicine and telescreening. So, to summarize, artificial intelligence is a disruptive technology which has myriad applications at present and in the offing for the medical field. It has revolutionized ophthalmology through aiding in screening and diagnosis of regularly encountered diseases like keratoconus, cataract, diabetic retinopathy, age-related macular degeneration, ROP, glaucoma, and so on and so forth. It has infused accuracy in pre and post-operative calculations in cataract and refractive surgeries. The prediction of systemic diseases through ocular measurements with AI is expected in the future. AI should always be remembered as a double-edged sword. Hence, caution needs to be exercised by including the supervisory human touch. So, always, AI should not be left alone. We should always provide the hand holding to both AI as well as the workforce. Thank you.